Good morning, everyone. Bob Ravenscroft, Vice President for Advancement, here for the December 1st, 2020 press briefing. We'll do the routine, run through some stats. There were quite a few advanced questions. We'll go through them pretty systematically, and then we'll open it up for questions. Our midnight census was 510 patients at Bryan Medical Center. We presently have 112 COVID-19 patients hospitalized that are presently COVID positive. 50-50 split. 56 are from Lancaster County, 56 are from outside of Lancaster County. There are an additional 31 COVID-19 patients that are no longer infectious, so it brings the total to 143 COVID-19 patients at Bryan right now. There's another 12 that are still pending their result at midnight, so you can add a couple to that. Right now on ventilators, there are 9 of our COVID patients. 2 of them are Lancaster County residents. Of those that are no longer infectious, there are 7 more additional patients still on ventilators. 13 of those currently infectious are in ICUs. An additional 7 that are no longer infectious are still receiving ICU level care. We've been working on this for quite some time. There's really kind of 2 components for us. There is the ethical framework and then the palliative care framework. The tenets of our ethical care standards address these things: autonomy, proportionality, fairness, accountability, transparency, and consistency. Our first draft of our ethical framework was entered onto our COVID-19 intranet site for leaders on July 2nd of 2020. Regarding the palliative care guidelines, we drafted those earlier this year, and then they were updated on November 6th. As you guys saw, and some of you reported on it, the state just released its guidelines. So what we're doing right now is cross-referencing our existing plan with what the state's new guidelines indicate should be done. And really what we're doing is determining if ours are more stringent than what the state suggests, maybe needs enhancements, or evaluate if everything that is in there is appropriate for a large tertiary medical center such as ours. We honestly suspect them to be very consistent. We are all kind of working from the same sources of information, and the team tasked with doing that crosswalk is to report back to the senior team on Friday. So we'll come back to you with more on that. Well, one thing I want to make really clear, the overwhelming majority of Bryan's admissions do not go through the transfer center. We had been receiving reports from the transfer center. They started on October 27th. We got one on October 28th. Then again on November 3rd, 4th, and 7th, and we have not received reports from them since then. On the 7th, over the previous 3-day period, we had received 5 admissions from the transfer center over that 3-day period. Obviously, many more are coming from direct admits. Regarding a uniform state policy, I think, as I previously mentioned, that the large tertiary and quaternary centers here in Nebraska are going to be pretty much in line with each other. The Hospital Association endorsed it yesterday, so I guess by proxy, as members of that, participating in those calls, we do too, but we'll be doing some additional crosswalks. Again, we've all been leaning on the same kind of sources of information. The University of Pittsburgh has been publishing on that, and then there's the Massachusetts model that was referenced in, I don't remember if it was the Journal Star or the World Herald this morning, maybe it was both. We're all using those, so again, I think it will be really, really consistent. As far as problems, I'm not sure this policy is going to be the source of problems. It's going to inform and maybe in some cases protect institutions if we have to make some of these horribly gut-wrenching decisions by bringing structure and consistency and fairness to it. But really, the issue still rest with supply and demand for, most importantly, our ICU and progressive care beds and available staff. We are going to know yet this week on the delivery date and the quantity that we are going to get initially. We have time blocked for pharmacists and physicians kind of beginning potentially as early as Thursday, going forward to update and educate you all on the vaccine and the process we're going to be using. So more to come, but we hope to know really in the next day or two what our count is going to be and when they're going. As you know, the FDA has some big hearings on December 10th, and then I think the Moderna one was on the 14th. So more and more information to come there. Right now, there are 3 tiers. The first tier is for direct patient care colleagues that work in what we would call either warm or hot zones. They will be the first tier to get it. The second tier, kind of in broad terms, are those with direct patient care that might be in cool or warm zones. The third tier would be employees that all remaining clinical areas, and then also administrative and support staff such as myself. So those are kind of the 3 tiers and how they will be sequenced once we get our hands on this. At this time, no. However, it's fair to say that this is a evolving situation as the initial rollout occurs. I know I've personally had conversations with colleagues at some very prominent academic medical centers where they are absolutely considering it. Additionally, I think we've seen that airlines are going to be asking for, some airlines have announced they'll be asking for proof of vaccination for travel requirements. So again, I think this will be an evolving issue. And I can tell you with a fair degree of confidence that the vast, vast, vast majority of our team will be lining up to get this. We do know at this point every indication it's safe. There's new information coming out. It has the potential to be what is called a super vaccine, meaning the manufactured one is better than the one human immunity builds up. And I think some of the ethical concerns are being alleviated here based on how the Pfizer and Moderna ones were produced. You know, there were no stem cells or fetuses involved in that. Again, that's as far as I want to go. We will have pharmacists and physicians covering this in detail. To get back to the question, at this time, not mandated, but it is an ever-changing situation that will be evaluated, so that could change as we learn more. It's a great question, and that's what we're doing right now. We have a whole team working on this. Edgar's involved with it. If you need a follow-up question, I'll be the conduit here. But our team is really working through that right now, and by unit, we're looking at how do you stagger this. Do you receive your vaccine in advance of a scheduled 2-day off period, things like that. But we have a team working through that because you absolutely wouldn't want a lot of negative reactions, which are not anticipated, but you wouldn't want that to debilitate the staff. So we'll be very careful about that. What it's really intended for is if we get slammed as a state and there's literally no places for patients to go, this crisis standard of care plan is for, fairness, transparency, consistency, proportionality to be rationed under those parameters. As far as testing, I don't have the detailed breakdown here. Our drive-through was at its typical, full level of about 144 individuals yesterday. We only have 115 pending right now, so it looks like the in-house or the outsourced labs are keeping up. But to answer your question, Nicole, I think we've been keeping our fingers crossed, but it's been pretty ominous with the Thanksgiving travel that occurred across the country and the get-togethers here that we're hoping against all hope or for all hope that we don't see a surge upon a surge, but we're preparing for that in case it occurs. I don't know if I would say policies. There are ongoing discussions with the long-term care facilities. There are a number right now. We do have patients in the hospital that they have nowhere to go. So I don't like the term warehousing, but we are essentially caring for patients that could be discharged if there was a place for them to go. So I think if the best way to describe that, if a patient absolutely needs hospitalization, they should be coming to a hospital. But continued work continues with our critical access partners on how we can help them through telemedicine. Same thing with some of the long-term care facilities. It's a shell game every single day. In fact, this topic, it might be one to bring some of our care management folks to, because it is a real issue. If, what do we have in here today? 143 total patients. 70 of those are in general care. I don't know how many of those in general care are just waiting for their where they live to accept them back or not, but it's fair to say there'd be a large number. So we'll get you better information on that, but it remains a real issue. Okay, well, that would be heartbreaking if people don't come to a hospital when they need hospitalization for fear of being turned away. That's not occurring in Nebraska. We make all of these contingency plans for that not to occur. But based on kind of Matt's questions about the long-term care, you can extrapolate that to our critical access hospitals. The best thing they need to do is talk to their physician, and they will direct them on, taking care of yourself at home, other options, or if hospitalization is required. But Bailey, we sure hope people, if they feel they need to be hospitalized, they should be exploring those options, and we are not in that position where we're turning them away. We are in a position where you're working with critical access hospitals, long-term care, private practice, primary care physicians on how to best care for patients safely if they do not require hospitalizations. That's probably a tough call for the individual to make, certainly for me to make, but in consultation with their physician and our staff, they will get them to the right spot. So this was from yesterday, and the numbers will differ slightly from what we report because, again, we take a midnight snapshot. But this is a real issue, guys, for how clogged up your hospitals are getting. So when you look at Lancaster County, yesterday on the 30th, Bryan had 159 COVID patients. Again, a little bit different than what we reported at midnight because people come and go throughout the day. If you look at some of the other big ones in the state, Bergen, 71, Emmanuel, 43, Lakeside, 43, Methodist, 55, Nebraska Medical Center, 110. Honestly, those are kind of the biggies. Regional West, 49. That's about it. I mean, the places with ICU beds and tertiary level care are pretty dang full. It shows where we're at from ICU percentage, and in the Bryan case, we have 12% of our ICU beds available at this point in time. A number of them are slightly above the 25% threshold and some slightly below it now. But those are staggering numbers, and they're staggering numbers for us as well. I think it is fair to say, Andrew, hospitalization rates, especially when you look at, the state as a whole, and even here at Bryan, have stabilized. They have stabilized at what is our historically high level. I do think the public service announcements that the state has issued, you've seen more assertive messaging from specifically, I think, the Med Center and us. I do think they're having an impact, and that's anecdotal based on what I observe, and certainly the feedback we receive from putting those messages out. How quickly could that change based on how people conducted themselves for the weekend? We're going to know in 7 to 10 days. And that's really the best answer I can give there. It's a concern for us, and frankly, I've had some conversations with a colleague of mine, chief nursing officer. It's like, what do we do post-pandemic? There's going to be a decompression time based on what these teams are seeing on a daily basis. So I'll see if there's anything we can get you on, if our EAP programs or other services have been taxed, to give you some information. But it's absolutely a concern of ours of how not just our staff, but society as a whole is going to respond to this as it potentially gets a little more dire over the winter months. And then when we come out on the backside, I think there's going to be a lot of work to do in these areas for a lot of people. I do know that we will continue masking for the foreseeable future because, one, it's not 100% effective. Two, we're still learning about it and so forth. So we will continue that in the short term. I think it's going to depend on how many people get it and then how quickly it's going to be rolled out to the community and so forth. But I can tell you this, I didn't have this conversation, but I was talking to John before I came down here, and he saw one of our pulmonologists in the hallway and just asked how they were doing. And this was secondhand, but what the pulmonologist said, he says, yeah, you know, we're doing better despite kind of the volume we're seeing, because the vaccine is presenting a light at the end of the tunnel. Without that light at the end of the tunnel, it was getting very, very difficult for folks. So immediately, this vaccine is going to give us a charge of hopefulness and energy, and then we will evaluate what operational procedures will still be needed to care for patients safely. Obviously, that'll involve when do you begin ramping back up as your capacity allows. What type of procedures, what type of testing might be required going forward, all kinds of things.